We'll give everyone another minute or so to keep filing in, and then we'll get started, everyone. All right. So as people continue to arrive, I'll just say hello. I'm Rachel Shapira, and I want to welcome you on behalf of the NSGC webinar subcommittee, and thank you for joining today's member webinar. The title of which is Genetic Testing for the Epilepsies, a New Practice Guideline. A few housekeeping notes before our speakers get started. We do encourage questions, which you can ask throughout the presentation by posting them in the Q&A. You're also welcome to use the chat to chat with other participants. However, all of the attendees have been muted as a courtesy to our presenters. At the end of the presentation, we will be reading questions aloud for the last 10 minutes, but you don't have to wait until then to pose the questions. Our speakers today are Natalie Lippa, Beth, Rosen, Sheidley, and Lacey Smith. Natalie is an assistant professor of genetic counseling at Columbia University Irving Medical Center, where she's the co-director of genetic counseling at the Institute for Genomic Medicine. Since joining Columbia, she's focused on the genetics of neurological disease with a particular interest in epilepsy. In this research role, she curates variants and assesses genotype-phenotype correlations with the goal of identifying new gene-disease relationships and communicating diagnostic results back to families. She is the senior author of the NSGC Practice Guideline for genetic testing in the epilepsies. Beth is a licensed genetic counselor with over 25 years of experience in clinical genetic counseling, research, and teaching. Her career has focused on the genetic basis of common neurodevelopmental diagnoses, including autism and epilepsy. Beth is the co-director of the Epilepsy Genetics Program at Boston Children's Hospital and the senior genetic counseling program manager for neurogenetics. She's a PAB member for the Epilepsy Foundation and the co-editor of Genetics for the Epilepsy Foundation website. Beth was the lead author for the NSGC Epilepsy Genetics Systematic Evidence Review. And finally, Lacey Smith is a clinical and academic genetic counselor within the neurogenetics program at Boston Children's Hospital, where she serves as the genetic counseling program manager for Epilepsy Genomics. Her research interests aim to better understand the genetic contributions to the epilepsies, particularly through exome and genome sequencing studies and variant curation efforts. She was the lead author on the NSGC Practice Guideline for genetic testing in the epilepsies. And I will pass it over to Natalie.
Thank you so much, Rachel. As Rachel said, my name is Natalie, and we hope by the end of this webinar that you'll have a greater understanding of the grade process for developing evidence-based guidelines. We hope to explore the key findings from our epilepsy and genetic testing systematic evidence review and meta-analysis. And then finally, we plan to discuss genetic testing strategies for individuals with epilepsy. And on behalf of Beth, Lacey, and myself, we have no conflicts of interest to disclose. So to make sure that we are all on the same page, I wanted to provide some background. To begin, a seizure is an abnormal synchronized electrical event in the brain that typically results in an outward clinical manifestation. Epilepsy, however, is really defined as the occurrence of 2 or more unprovoked seizures, or one unprovoked seizure with a propensity for others. Epilepsy is clinically variable in terms of age of seizure onset, type of seizures, EEG findings, neuroimaging results, and response to anti-seizure medications. Neurodevelopmental, psychiatric, and behavioral comorbidities can also occur. And when we're thinking about the clinical heterogeneity of epilepsy, it can be difficult to determine the specific epilepsy diagnosis in an individual. And this is important because it can provide a framework for understanding the type of seizures that the individual has, the other seizure types that are more likely to occur, potential triggers for seizures, and it can often provide details about prognosis. A specific epilepsy diagnosis can also inform the risk of other comorbidities, including learning difficulties, intellectual disability, psychiatric features, and importantly, mortality risks, such as sudden unexpected death in epilepsy. It's noted that such classification can often guide the selection of anti-seizure medications. In 2017, the International League Against Epilepsy developed a diagnostic tool to help clinicians diagnose and characterize patients with epilepsy. They present 3 levels, starting with seizure type, such as focal or generalized seizures. After diagnosis of seizure type, the next step is to diagnose the epilepsy type. So that could include focal epilepsy, generalized epilepsy, or combined generalized and focal epilepsy. The third level is that of epilepsy syndrome, where specific syndromic diagnosis can be made. And this can include things like developmental and epileptic encephalopathy, Dravet syndrome, or self-limited neonatal epilepsy. This classification system emphasizes the need to consider etiology, such as a genetic diagnosis, as it could carry a significant treatment implication. Additionally, this system also incorporates comorbidities that can occur in patients with epilepsy. And like etiology, it's important that the presence of comorbidities be considered for every patient with epilepsy, enabling early identification and appropriate management. As we all know, the field of epilepsy genomics has significantly expanded in the last decade. Gene discovery in the epilepsy was first focused in those with familial epilepsy, and then with the introduction of NGS technology, gene discovery has sharply increased, similar to other specialties in neurology and medicine. This diagram here illustrates the key discoveries over time within the field of epilepsy genetics. Despite these recent advances in genetic testing technology, as well as progress in identifying novel genetic mechanisms, there are limited consensus and evidence-based clinical practice guidelines for genetic counseling and testing in patients with epilepsy. Previous consensus-based and early evidence-based guidelines offer somewhat conflicting recommendations, have vague language, and many were developed prior to the widespread adoption of NGS technologies. Anecdotally, our practice guideline group has seen this lead to inconsistency in care. In 2016, NSGC called for practice guideline topics, and genetic testing and counseling for patients with epilepsy was chosen as one of the first topics. So as we embarked on creating these evidence-based guidelines, there were really 8 standards to consider. The first is to establish transparency, including who's funding the guideline and how it was developed, and making the guideline publicly available. The second is the management of conflict of interest. So for instance, within NSGC, lead authors cannot have a real or perceived conflict of interest. The third is guideline group composition. This should be multidisciplinary and balanced. And importantly, it should be informed by systematic evidence review. This is really a key component. The fifth one is establishing evidence foundations for and rating the strength of each recommendation. This should be transparent and structured. The sixth is to articulate the recommendations in standard formatting and in clear wording. The guideline should undergo external review. Oops, sorry, I zoomed ahead here. The guideline should undergo external review, and it should include language for updating, including the regular assessment of new evidence and the timeline. So what is GRADE? Well, GRADE is really a framework to develop the guideline with these 8 standards that I mentioned. It stands for Grading of Recommendations, Assessment, Development, and Evaluation. This is a transparent framework for developing and presenting the summaries of evidence and provides a systematic approach for making clinical practice recommendations. It's used by organizations worldwide to develop evidence-based guidelines. And there are numerous publications describing grade methodology, as well as the application to different aspects of grade development. Two key aspects of grade is the evaluation of the strength of the data from the systematic evidence review. And importantly, the final recommendation should be grading. So for instance, it might use the term strongly recommend or conditionally recommend the intervention that you're studying. This slide gives you an overview of the evidence-based guideline development process within NSGC. You can see here that there are multiple steps and deliverables at each stage. A methodologist and librarian is included in the process, and is quite a lengthy process because it includes reviews at multiple stages by the practice guideline committees, NSGC members, and the NSGC board of directors. You'll also note here that there are two main author groups, the systematic review group and the practice guideline group. And I do want to review the differences between the two author groups. Simply put and broadly put, the primary goal of the SER is to collect data and complete the meta-analysis. And the primary goal of the practice guideline is to use that evidence to create the actual practice guideline. Overall, the SER reflects the extent of our confidence that the estimate of the effect are correct, while the practice guideline reflects the extent of our confidence that the estimate of an effect are adequate to support a particular decision or recommendation. So in this process, the first thing that's developed is what's called the PICO questions. And when thinking about a practice guideline, we need to consider the population of interest. So for us, that was patients with epilepsy. We then need to think about the specific intervention that we want to study, what you would be comparing it to, timing, outcome, and the setting that you're researching in. The SER then systematically conducts a literature search. They review abstracts for inclusion and exclusion. Those that are included in the inclusion complete a full data extraction, and these data are used in the large meta-analyses. Importantly, for the data that has been extracted from the literature, they're assessed for quality and risk of bias. The practice guideline group takes all of this data and all of this evidence that the SER extracted and summarizes and uses that to format the recommendation and write the recommendation. To make this recommendation, they really review a number of factors like the priority of the problem, the desirability of the effects, the undesirability, the certainty of the evidence, the healthcare value, the balance, the resources that could be required, cost effectiveness, equity, acceptability, and feasibility. And so the final recommendation comes from a review of all these factors. In the end, a recommendation is written. And so a strong recommendation is one in which the working group concludes that the desirable effects of adhering to a recommendation outweigh the undesirable effects. A conditional recommendation is one for which the desirable effects of adherence likely outweigh the undesirable effects, but the working group is not confident in the trade-offs. So I hope you have a better understanding of the grade process. And now I will pass this off to Beth so she can get into the details of the SER.
Thank you so much, Natalie, for an excellent review of the grade process. I'm happy to be here today to talk about the systematic evidence review, which began shortly after the proposal for practice guideline and evidence review were approved by the NSGC. So this was in 2016, and we really began our work in earnest in 2017. And we really began as a group by thinking about what question is it that we want to be able to answer. Do we want to be able to look at genetic testing? Do we want to be able to look at genetic counseling? Do we want to be able to look at both? And so in formulating our PICO questions those were the things that we really wanted to be able to look at. Natalie, I don't seem to have control of the slides yet, so maybe you just want to forward through to the next slide. So the questions really the big overarching questions were, can genetic testing be recommended for individuals with epilepsy? And if so, which tests? Next slide. So if you're interested in reading all of the nitty-gritty detail from the evidence review, you can go to this publication from November 2021 in Epilepsia. I'm going to highlight major findings so that we make sure to have time to hear about the practice guideline as well. Next slide. So our PICO questions obviously was developed with the population in mind of individuals with epilepsy, but really any type of epilepsy and individuals of any age, because we didn't want to just focus on, say, infants or seizure onset early in life. The interventions that we chose to focus on were somewhat targeted because we quickly realized that if we included every single genetic test, we would have far too much literature to go through. So we focused on genome and exome sequencing, multi-gene panels, and CGH-CMA. We looked primarily at outcomes that had to do with yield, but we also wanted to be able to look at aspects of clinical and personal utility, so changes in treatment or management, aspects of psychosocial well-being. We did not set any restrictions on the timing of the testing, again, at certain points of the lifespan. And the settings that we included were really any clinical or research setting that incorporated genetic testing. Next slide. So just to give you a bit more of a detailed sense of the kinds of utility that we were hoping to look at, in addition to just test yield, we wanted to be able to assess the extent to which there was inclusion in the literature regarding clinical utility, as outlined here, and personal utility. So those aspects of genetic counseling that are sort of near and dear to our heart that have to do with the psychosocial impact, recurrence risk estimation, reproductive planning, that sort of thing. Next slide. So ultimately, we screened almost 6,000 articles, so abstracts, 5,985 to be exact. And this meant that our group of authors went through each of those abstracts, and we were assigned to go through them in pairs. So each of us reviewed on the order of 600, 700, 800 abstracts to determine whether those papers could be included for full text review. We ultimately excluded 5,596 of them. So we ended up with 389 articles that we then assessed in full text mode to determine ultimately eligibility. We excluded many articles at that point. Once we got into the nitty-gritty of the article, we were able to find things that led us to need to exclude. So either it turned out not to be primarily patients with epilepsy in the cohort. In some instances, there wasn't actually genetic testing performed, even though the abstract made it sound as though there was. In many instances, there wasn't an outcome of interest. So maybe the yield wasn't reported, or there were no non-yield outcomes that were reported. And then in some instances, the study design didn't meet our criteria, so we needed to exclude. So at the end of the day, there were 154 articles included in our quantitative analysis, where we looked at yield of different test modalities, and then 43 articles where we looked at what we called non-yield outcomes. This was a qualitative assessment, and again, this was those aspects of utility that have to do with medical management, prognosis, or personal utility issues. Next slide, please. So overall, across the different test modalities, and again, this was exome and genome sequencing, multi-gene panel, and microarray CGH-CMA, the yield was 17%. Not surprisingly, there was a slightly higher yield depending on what type of epilepsy the cohort had. So the highest yield was for individuals with DEE or developmental and epileptic encephalopathy. The lowest yield was for individuals with focal epilepsy or cohorts of focal epilepsy. The yield was higher among cohorts with neurodevelopmental disorders as comorbidities. There, across all of the tests, there was no difference whether there was a structural brain malformation absent or present in terms of test yield. That did vary a little bit when you start to break it down based on the specific type of test. But again, all tests looked at together collectively, no difference in yield based on that aspect of phenotype. Next slide, please. So when we looked at the individual test yield, not surprisingly, the lowest yield was for array CGH-CMA, where the yield was 9% based on 43 studies total with an N of 5,654 individuals. Multi-gene panel yield was 19%, about double the number of studies there, 81, and a much bigger N. Exome sequencing, the yield was 24% based on 40 studies with an N of around 3,000. And then finally, whole genome sequencing yield was the highest at 48%, but that was based on only 4 included studies with an N of 350. Next slide, please. In terms of clinical or personal utility, this was quite limited in terms of what we were able to ultimately extract. There were 24 studies that reported in a systematic way regarding the impact on treatment or management. So the cessation of a particular drug that's contraindicated, the introduction of a drug that is more efficacious based on the type of epilepsy, for example. There was one study that reported changes in subsequent evaluation or procedures or hospitalization. So if there's a diagnosis, for example, that suggests there's an increased risk for a renal abnormality, so a patient is sent for renal ultrasound, whereas they might not otherwise have been just based on their epilepsy diagnosis. There were 2 studies that reported an ability to provide additional information about prognosis, which would not have been possible prior to the genetic etiology being determined. And then there were no studies, sadly, that systematically addressed the psychosocial impact, recurrence risk estimation, or family planning issues. Next slide, please. So as you can imagine from what I've just shared with you, there were major limitations of the literature, and this actually became quite apparent to us even during the abstract review. But across the studies in terms of the epilepsy phenotype, although most of the articles utilized the criteria from the International League Against Epilepsy, or ILAE, which is the primary sort of professional governing body in the world of epilepsy, there was very inconsistent reporting of epilepsy phenotypes. There were mixed cohorts where the authors didn't separate them out in terms of reporting yield or outcomes. Some papers didn't describe the epilepsy phenotype at all. And then in quite a few instances, there are what we would refer to as convenience cohorts where there was a yield reported based on whichever individuals happened to be included. So there was not a lot of prospective study design going on in terms of these outcomes. It was just whoever happened to come to clinic or whoever happened to be identified through medical records review. Similarly, there were limitations that we had to deal with respect to the test modalities that were utilized. So again, inconsistent reporting. there was quite a bit of variability in the number of genes included on the panels. And in some instances, there were multiple test modalities used either in a tiered fashion or simultaneously. So it was difficult to extrapolate, let's say, in a group of individuals who had exome, who were included in a cohort, but that cohort also included many individuals who had exome as a second or third tier test following a 500 gene panel plus a microarray. Clinical utility was, and personal utility were really not consistently reported or systematically assessed across most of the literature. So this is a major area really for future research, and something that we were a bit disappointed not being able to provide more data and more analysis regarding, but it is what it is. And I guess I would say for those of you who are attending the webinar today, that's an area that's really ripe for study for anybody who is interested. So I will pass things on to Lacey at this point to continue telling us about the practice guideline.
All right, great. Thank you, Natalie and Beth, so much for your overview of both the guideline process and the SER data that ultimately informed the guideline. So my portion of the talk is going to focus on the formulation and the content of the practice guideline. So at the outset, we wanted to preface the recommendations with a few disclaimers. So first, the guideline would cover genetic testing for what we call the unexplained epilepsies. So epilepsy is considered unexplained when, according to history, physical exam, brain imaging, and other standard evaluations, the cause of the seizures cannot be attributed to any sort of structural, metabolic, infectious, or other acquired etiology, such as trauma or stroke. So we wanted to note that metabolic and structural etiologies can have a genetic basis. And if those are being considered, then more targeted testing based on those indications should be pursued. And then also routine evaluations for an individual presenting with new onset seizures or new onset epilepsy were beyond the scope of the guideline. And additionally, if seizures were simply part of a multi-system presentation with extra neurological features, or the constellation of features suggested a specific syndrome, then targeted testing most appropriate for that indication should be pursued. So an example of this would be something like Angelman syndrome or Fragile X syndrome. So we made two recommendations, and I'll go through each one, including the evidence that informed the recommendation and also that supported the corresponding strength. So our first recommendation, we strongly recommended that all individuals with unexplained epilepsy be offered genetic testing, regardless of age of onset. So this included broad-based testing, including either exome or genome sequencing or large multi-gene panels as first-tier testing. We conditionally recommended exome or genome sequencing over multi-gene panel, as most clinical scenarios would favor exome or genome sequencing. However, there are specific clinical scenarios in which a multi-gene panel would be favored as the first-tier test. And finally, the multi-gene panel should be broad in scope and should also include some sort of deletion duplication analysis. As Natalie mentioned earlier, in order to reach a strong recommendation that we gave to our first recommendation for genetic testing, it must be clear that the desirable effects or the benefits would outweigh the undesirable effects or the potential harms. So early in the grade process, our group defined these critical and important outcomes. And in addition to the diagnostic field, these were three of the outcomes that we defined as critical and important. And these are the outcomes that factored into making our recommendations. So first, impact on treatment and management. we know that a genetic diagnosis in the epilepsies can inform choice of anti-seizure medication, direct treatment, such as the ketogenic diet. It can alter plans for epilepsy surgery, allow for patients to be eligible for either ongoing or upcoming clinical trials, for example. And beyond targeted treatments, we know that a genetic diagnosis can inform decisions to continue anti-seizure medications, wean anti-seizure medications in the cases of self-limiting epilepsies, or initiate palliative care in life-limiting conditions. Second, the ability to inform disease prognosis. This could be to establish prognosis in the case of early diagnosis when the full phenotype may have yet to reveal itself, or may alter or provide new information on the prognosis. Examples of this being a diagnosis that supports a self-limiting epilepsy or an early diagnosis of a neurodegenerative condition. And lastly, we consider the impact on reproductive recurrence risk. As Beth mentioned, there's very little systematically collected evidence that was available for the SCR that we could base this off of. There are several studies that were included in the SCR that mentioned individuals using the genetic diagnosis to inform pregnancy management, but there wasn't a lot of data in that regard. But also in terms of this potential harms, we identified that for some families, a genetic diagnosis could provide newfound awareness when people may not have realized that the risk for epilepsy could be inherited. So overall, the benefits outweighed the potential harms for genetic testing, much of which were largely psychosocial in nature, which could have been alleviated or supported with appropriate pre- and post-test counseling. So getting into the evidence that formulated our recommendations, I wanted to recall some of the evidence that Natalie presented earlier. So there's been and continues to be an explosion in the gene discovery in the epilepsies. There are hundreds of genes that we know to have some association with an increased chance of developing seizures or epilepsy. In addition, and I know there's a lot of information on this slide, and that's the point, not really to take home anything from this slide, any information about the actual gene or gene disease associations, but just to note that there's extensive phenotypic and genetic heterogeneity in the epilepsies. You can have a variance in one gene giving rise to multiple different epilepsy phenotypes, or one epilepsy phenotype being caused by variance in any one of multiple different genes. So that information plus the diagnostic yield ascertained from the SCR supported the recommendation for broad-based testing, such as exome genome sequencing or large multi-gene panels over the smaller gene panels or chromosome microarray. So here are the yields from the SCR, and also not only was the yield overall for panels quite large, but it also differed significantly based on the size of the multi-gene panel. So that's what informed our recommendation regarding the size of the gene panels. So in terms of our conditional recommendation of exome or genome sequencing over multi-gene panel, there are some clinical scenarios in which we'd want to order a multi-gene panel over exome or genome sequencing. So for example, if a patient has a distinct epilepsy phenotype in which you can pinpoint a single gene or group of genes that should be interrogated more robustly, that you might want the higher sequencing coverage or the better deletion duplication coverage that you would get on a panel, then you might want to order a panel over an exome or a genome, for example. Additionally, if a rapid turnaround time is required for treatment, so you might choose a treatment-based panel or one of the rapid panels, particularly if a rapid exome or genome sequencing is not available. And always, it's important to consider what's included and what might be missed based on the technology of each test. So this goes into a little bit more detail, and it reiterates a little bit of what I mentioned on the previous slide. So if a patient has a specific epilepsy syndrome, then a panel might be indicated. Whereas someone perhaps with a generalized epilepsy, non-specific features with autism, intellectual disability, then it might be more ideal to go more broad in scope with an exome or a genome. I will note that there are genes in which repeat expansions are common as well in the epilepsies, and a couple of examples are listed here. So while the SER did not include single gene testing, it was important to note that in our guidelines, there are instances where single gene testing would be appropriate or important, and there was clinical significance here. So we wanted to make note of that. I don't need to go into a lot of detail here given the audience for this particular webinar, but given that a significant portion of genetic testing is being ordered in neurology clinics without the support of genetic counselors or access to medical geneticists, we did include a large section in the practice guideline on scope and limitation of different testing options for healthcare providers and clinicians to consider in the test selection and approach to testing. We also included this visual aid to provide guidance as well. So as Beth mentioned, the SER, the data included in the SER couldn't distinguish between sequential testing and whether or not, tests were ordered in a specific order, whether testing was ordered after a negative test, for example, an exome was ordered after a negative panel or as a first-line test. So we couldn't base our recommendations for tiered testing solely on the SER, simply because that data were unavailable. However, we were able to use data coming from the yield of each individual test and also additional data from the literature. So for example, exon level deletion duplication and the yield from that. Also, recent evidence that supported increased yield from exome and genome sequencing reanalysis over time. So we're able to incorporate that. So these things were of clinical significance and importance to include in a guideline, even though they didn't necessarily come from the SER, but we were able to find supplemental data in the literature to support these additional recommendations. So this figure, we included it in the guideline. It outlines the different approaches one could take. So either starting with the targeted testing, a large panel, or exome and genome sequencing, and then proceeds with next steps to consider if testing is non-diagnostic. So moving on to recommendation number 2. And recommendation number 2 focuses on the manner in which genetic testing could be implemented. So we strongly recommended that genetic tests be selected, ordered, and interpreted by a qualified healthcare provider in the setting of appropriate pre-test and post-test genetic counseling. Now, we defined a qualified healthcare provider as someone who has some sort of training or specialized knowledge in genetics, who has the ability to discuss the scope, benefits, limitations, psychological implications of genetic testing, but also someone who can evaluate and interpret a genetic test result in the context of a patient's presenting phenotype. So we acknowledge that there are a number of healthcare providers who can order genetic testing who may not necessarily be licensed in the field of genetics specifically. And we didn't want to limit or restrict the ability to order testing to certain groups, but rather it was important to define skill sets that might be appropriate. So there wasn't a lot of data in the literature pertaining to the benefits and limitations of genetic counseling in the epilepsies specifically. However, we were able to identify some outcome data pertaining to different elements of genetic counseling, and we're able to include that. So we were able to find that individuals who receive genetic counseling are known to have increased knowledge, decreased anxiety, and increased perceived personal control. As I mentioned earlier, there are reports of individuals using a genetic diagnosis for pregnancy management decisions. Additionally, for the second portion here, we have seen the impacts both in the literature and collectively in the author group within our own clinical experiences of adverse outcomes when genetic tests are being ordered by providers who may have less experience in ordering and interpreting genetic tests. This is most often seen in interpreting variants of uncertain significance, either VUSs being dismissed entirely, not being evaluated thoroughly, not being followed up on with parental segregation testing, diagnosis being missed or just dismissed and cast aside. We've also seen VUSs being considered definitively diagnostic and later downgraded to benign, and the medical and psychosocial implications that come along with taking away a genetic diagnosis from a family. We've also seen delayed diagnoses due to incomplete testing or selection of tests that would not identify the gene or the type of variant commonly associated with a particular epilepsy syndrome or phenotype. So that wraps up our two specific recommendations. However, we also considered and addressed a few other elements that would either impact or be impacted by these guidelines. Overall, we found that genetic testing was largely acceptable to relevant stakeholders, including providers, patients, and families. These same groups appeared to value similar outcomes of genetic testing and genetic counseling. We were able to extrapolate data on healthcare disparities in epilepsy management and genetic testing in other specialties. We found that individuals from underserved communities were less likely to be referred for or undergo genetic testing. And our hope is that by having standardized guidelines and formal guidelines in place, that would increase access to genetic testing for all individuals affected by epilepsy. And lastly, we consider the feasibility and the resources required to implement these guidelines. Since genetic testing is already being done across many clinics, this would likely impact most in terms of scale. So just increasing the amount of genetic tests being ordered or the type of genetic tests that are being ordered. However, we also are aware and acknowledge that many genetic tests are being ordered in neurology clinics that just don't have the support and the resources to order genetic tests. We've communicated with neurologists from institutions that might not be large academic institutions that don't have the resources, that don't have the genetic counselors or the in-house medical geneticists that they can refer patients to. So it's those institutions that might have the most difficulty, and in what ways can we provide support for those institutions? And we hope that by having these guidelines, it'll influence and highlight the importance of having these support services in place to increase access, but also, what can we do as genetic counselors? And I would say in the interim, any opportunities to increase educational opportunities to our neurology colleagues about how to order genetic testing, what are important factors to consider in genetic testing, because we can't clone ourselves and be available for all these consults. So just anything that we can do to support our neurology colleagues, I think would be beneficial. So that concludes my part of the presentation on the actual practice guideline. And just lastly, to wrap up, these are two guidelines as our two recommendations as we have them written in the guidelines. And as three of us, Natalie, Beth, and I collectively, and as well as our respective author groups, would just like to thank a few people here. First, Katie Helbig, who is genetic counselor at CHOP, who initially submitted the proposal for this practice guideline, and without her, we all wouldn't be here today. And additionally, I know the SCR would like to thank the Boston Children's Hospital medical librarians who supported a lot of their paper and literature reviews. We would all like to thank our NSG Practice Guidelines Committee and liaisons through the years, Beth, thank you for reminding me that we've been doing this since 2016. So there are too many to list in this slide and make it actually legible for you all to read. So thank you to all who've been involved. The AES Guidelines and Assessment Committee, so the American Epilepsy Society, provided incredible feedback to our practice guideline in consideration of a formal endorsement of our guidelines. And of course, our respective author group members. And with that, I think that wraps up our presentation. We'd be happy to take some questions.
Thank you so much, all three of you. That was fabulous. And we have a lot of questions already. And so I will get started with some of them and preface this by saying we probably won't get through all of them today. But I wanted to start with some questions about the recommendations themselves that people have. So one of them, is there any recommendation for prenatal cases when there is a family history, first or second degree, of epilepsy without a known etiology?
Yeah, I would say that we have no data on just screening when there hasn't been an individual in the family whose genetic etiology has not been identified. Typically, we recommend testing the individual with epilepsy to identify that genetic cause, and then offer testing to either other affected family members or pre-symptomatic testing or prenatal testing.
And then a lot of questions about the testing itself. So one of them, can you clarify when whole genome versus whole exome should be used?
Yeah, and that's gonna, so there was limited data on the genome sequencing for the SER, and it's limited availability clinically right now. So we included that together largely as genome sequencing becomes more clinically available. So I think genome sequencing has the ability just to detect more types of variants. So as it becomes more available, it would just allow for less sequential testing. So reduce the need for other follow-up testing rather than, doing an exome and then needing to do a chromosome microarray. It also has the ability to detect other variants. So I think I envision it becoming the first line test as it becomes more available instead of doing exome sequencing. So I think it's more of a limitation of availability and payer reimbursement and payer coverage right now.
I'll say relatedly, there was a question about CMA specifically. If you have any specific recommendations doing it either concurrently or as a first step before whole exome or genome.
Yeah, and we included it as kind of like a last tier test in the guideline, just because the yield is so low for chromosome microarray. I think it varies in clinics. A lot of the labs right now who are doing exomes are calling CNVs, are able to call CNVs from exome data. So I think it's, so a lot of people, our clinic right now is doing a lot of just doing the exome and seeing what comes from that, and then following that up with a chromosome microarray if the CNV calling from the exome isn't as good or as inadequate. Because sometimes we would do it concurrently and then the exome would call the same CNV that the microarray would call. So, it's just kind of wasting time, it's wasting resources. So the exome sequencing is continuing to get better and able to call that. But of course, I wouldn't rely on that right now because it's still exploratory. It's still missing some things. So it's certainly to look at the reports and maybe getting in touch with the lab to see what might have been picked up and what might have been missed.
And then, thank you. And a couple of people also asked about mitochondrial genome and testing. Any recommendation for the inclusion of the mitochondrial genome was one of the questions.
So I don't think we had that data from the SER to specifically comment on that. I think that's one of the instances where targeted testing, if a mitochondrial condition is being suspected, then certainly include that when you order the exome. To be sure, include that in the order exome plus mito sequencing, if that's something that's suspected based on the phenotype.
And then this is a question that goes back to something you alluded to a little bit earlier, Lacey, which is authorization for getting this testing, and whether any of you can speak to the challenges of getting insurance authorization for whole genome or exome versus panels or other testing.
Yeah, and that's one of the things that we're hopeful that this guideline would help with for all the insurance denials that we get that says there's no evidence to support genetic testing in the epilepsies. We hope that between the SCR and the practice guideline that this would be some evidence, maybe fingers crossed, but we're fighting with you. We're fighting the same fight. And our hope is that by recommending it for all patients with epilepsy, and that's why we included some of that language, regardless of age of onset, for all the insurance denials that we say, oh, is your age of onset prior to age of 3? If not, we're going to deny it. So we were very specific in some of the language that we included to hopefully be more supportive in coverage, but insurance companies are still denying a lot of testing that we're recommending. So for example, I had a patient that I had a specific testing. I wanted to do a panel for specific indications. I could get an exome, but not a panel, but I wanted that panel for specific reasons because of the coverage over specific genes, but I couldn't get it. So it's a lot of fighting back and forth and it's a lot of appeals, but that's just where we are right now. And hopefully that continues to evolve.
Can I just add to that, which is, I think one of the reasons we wanted to look at non-yield outcomes in the SER was to be able, we were hoping to be able to provide data that suggests that a positive genetic test directly impacts treatment and medical management, right? Clinical utility and personal utility. There are some papers that are coming out now or that are sort of in the process of being reviewed, where that kind of data has been more systematically collected across large cohorts. But for the sort of one-offs right now, where you're trying to get approval, to the extent that you can include language in your submission around how you think this genetic test outcome may impact treatment decisions or medical management, and be really specific about what you have in mind, you might be more successful in your appeal. You know, that said, there are some insurance providers that just do not cover exome or do not cover genome.
Yeah.
Hopefully that's helpful.
And I know certainly even when we do have updated recommendations for what should be covered, there's often a delay before that recommendation translates over to approval on the insurance side. I wanted to shift gears a little bit to some of the questions about kind of the literature review in the SER. And one question, how was the data regarding health equity and disparities ascertained? Was this typically included in the studies from the literature review?
No, and that's not something that we looked at in the SER. That was not part of our primary goal to look at that.
So that was part of more of the practice guideline author group in terms of finding evidence to support our recommendations. We had to look at how this could affect health equity, and we pulled a lot of literature from non-epilepsy specific genetic testing publications, but that could really easily translate over to the epilepsy population.
Give me a moment, I'm just looking through some of the other questions.
Go ahead.
Oh, no, please.
No, I just saw a few questions about the publication date for the practice guidelines. So that is hopefully any day now that will be published through Journal of Genetic Counseling. The systematic evidence review is published already in Epilepsia. And so we can link that in the chat so that people can get access to that.
Perfect. I was going to say, I know there were requests for paper links.
Yeah, I'll put that now.
A question about the SER development. How is the test yield determined during SER? Some of the whole genome or exome sequencing publications do not strictly follow ACMG AMP guidelines for variant classification. Also, some articles classify a variant as VUS likely deleterious. Was the yield for pathogenic variants and VUS combined?
So whoever wrote this question has touched on one of the huge issues that we encountered when doing our abstract and full text review. We required that the authors be transparent about their methodology. That was not always the case. Most used ACMG guidelines, but not all. There were lots of idiosyncrasies around how people reported whether variants were pathogenic or not. And so there were many, many papers that we had to exclude on that basis. But this is really a major limitation because actually some of the papers were published prior to the guidelines even being published or implemented. So, another reason why it would have been nice to have prospectively collected data with all of these factors in mind. And if you read the SER paper, we actually make a point of calling that out in the discussion and recommendations section for future research. So you raise a really important issue and one that caused a great deal of what I guess I would refer to as pain and suffering for those of us reviewing the abstracts and the articles. And I noticed, I'm just going to answer this other question. Somebody was asking, how did you go about this review? Because it's a huge number of articles. And okay, guys, it's 2022, and we're just now getting around to publishing the practice guidelines. So what that tells you is, yes, it was very time consuming. So time consuming, in fact, that we twice had to go back and ask the medical librarians to do an additional lit search because so much time had passed from when the lit search that we were actively working on had been done and sort of what we've been able to accomplish. And that was with 8 of us in pairs reviewing all of these abstracts and articles. There are some tools that are used. So we use something called Rayyan, which is RAYYAN, which is an online tool for uploading abstracts and full text so that you can work in pairs without using things like Excel spreadsheets. But it still took a very, very long time because we're all people with full-time jobs and other responsibilities. So anyway, that's why it took 6 years. I guess is my short answer to that question.
Thank you for jumping in on that additional question, Beth, because the number of articles included was striking, to say the least. And I wanted to pull one more question that was posted in the Q&A in our last couple minutes. Any comments or research on psychosocial impact of the word epilepsy as an additional diagnosis in a patient with an identified mutation, syndromic features, and seizures?
I'm not sure I totally understand the question in terms of our evidence review and guidelines, because that isn't that wasn't part of the scope of what we were looking at. I would say, just in general, certainly words matter, and there's a long history of stigma associated with the word epilepsy, the word seizure even. So I think that's an interesting area of research, potentially, and there's certainly quite a bit of that in journals that focus on psychosocial impact and stigma, but it wasn't really part of the scope of what we were doing. I'm not sure if that totally addresses the question, or if Natalie or Lacey want to say anything in addition to that, but those are sort of my initial thoughts.
I don't have much to add. Yeah.
Okay, sounds good. And then one more maybe quickie. Is there going to be an official effort into promoting these guidelines to the neurology field professional organizations, kind of beyond genetic counseling?
Yeah, so I presented it at the Child Neurology Society meeting last Friday, and we are pushing and got a tentative endorsement by the American Epilepsy Society. So hopefully working with them to get this in the hands of epileptologists and neurologists as well. That's a great question. Efforts underway.
Good to know. So it is 2:01. So we are officially at time. Thank you, all three of you, so much. That was fabulous and informative. And on behalf of the NSGC webinar subcommittee, thank you to everyone who joined us today. And the webinar recording will be posted to the NSGC website within 48 hours. Have a great day, everyone.
Thank you so much for having us.